Dear participants of the third Prevent from Caries Symposium, welcome to the evening session. The speaker of this session is Dr. David Elliman, and he will be sharing with us his valuable knowledge about biomimetic dentistry. David Elliman received his undergraduate degree in microbiology chemistry from BYU and then graduated from the Dental School, University of the Pacific. Between 1978 and 2001, he worked in the U.S. Navy Dental Corps and the U.S. Army Reserve Dental Corps. He holds a private practice in Salt Lake City, Utah, since 1981. Along with Pascal Magnet, Simone Deliperi, and Ray Bertolotti, he is the founding scientific advisor to the Academy of Biomimetic Dentistry, and he has been teaching biomimetic dentistry since 2003. Dear David, it's a great pleasure to have you in our symposium. Thank you very much for accepting the invitation.
Thank you very much for having me. It's a great honor, pleasure to be speaking to this conference sponsored by Kent University and Turquoise Dental Club, Study Club. It's groups like this that are progressive, that are really making the world a better place in the world of dentistry right now. So this lecture, go ahead.
Okay, the screen is yours, please.
Okay. So this lecture will be about 60 minutes long, and it will be recorded and be available for review. We want everyone to understand that the 6 lessons approach to biomimetic dentistry is something that has been evolving for 25 years. The reason we call it 6 lessons is because my son Davey and I are avid golfers. Today there's a golf tournament called the Masters in the United States, one of the most important golf tournaments. But Ben Hogan was the world famous golfer that wrote the book that changed the way golf instruction was given. It was called 6 lessons, 5 lessons. So we have a 6 lessons approach to biomimetic mastership. And if we always start with why are we doing things, then I think that helps a lot, because if you did a Google search on adhesive dentistry today, you would have about 200,000 items come up. It would take you decades to go through those thousands of items. Michel Degrange, who is the editor of the Journal of Adhesive Dentistry, wrote this in 2006. The general practitioner and specialists alike is confronted with a mass of raw information, but it's neither sorted out nor put into a hierarchy, and often is contradictory. So adhesive dentistry still requires sophisticated procedures. They are highly operator dependent. However, the potential high quality result possible with adhesive techniques justify the special effort required. So what is biomimetic dentistry? When we look at biomimetic dentistry, it's a way to restore a tooth without full coverage retention form and resistance form. And it preserves 50% or more of tooth structure that is destroyed by traditional mechanically retained restorations. When we look at a failing amalgam that is causing redecay and cracks, we can remove the cracks and remove the redecay, and we still have a tremendous amount of tooth structure, but we have to be able to reconnect the tooth side to side, front to back, and top to bottom to be able to preserve the tooth as if it were functioning like a natural tooth. And with the techniques we go through today, there are 3 approaches to biomimetics. This is a stress-reduced direct approach. There are also indirect approaches and semi-direct approaches that we'll refer to. And my son and I have been teaching this program for this last year online. We invite you to look at our website, and if you're interested, you can contact us about further training. In the world, there's probably 10 teaching centers around the world that are teaching these 6 lessons approaches. So here are the 6 areas of importance, and they are put in a hierarchy. There's 6 areas that everyone who wants to master biomimetic dentistry have to be masters of it, understand what to do, how to do it, and most importantly, why you're doing it. And these are the 6 areas: the diagnosis and treatment of caries, the diagnosis and treatment of structural compromises, immediate dentin sealing and resin coating, C-factor control by decoupling with time and fiber placement, enamel preparation, onlay design, and then occlusal adjustments. But when we treat, the order of treatment is a little bit different. We do our diagnosis of structure in lesson 2 first, and then we treat our caries second, and we prepare the enamel third, and then we proceed with our immediate dentin sealing and resin coating, and then deal with the C-factors in our dentin replacement, and then we deal with enamel replacement, and then our occlusal adjustment. So here is lesson 1, the diagnosis and treatment of caries. Pascal Magnier and I in 2012 summarized the science that has been evolving over the last 3 decades on caries removal. And the foundation comes from Japan and has been amplified and studied around the world. I invite everyone to read this paper that Pascal and I wrote. It's very detailed, but if you follow the protocols here, you will not expose pulps, you will decrease endodontic treatment, and you will be able to conserve as much tooth structure as possible by creating what's called a peripheral seal zone and caries removal endpoints. When we have the concept of a peripheral seal zone, we want to create an area 2 to 3 millimeters that surrounds any areas that are deeper that could have decay in them. And these areas are detected with caries detecting dye. And so with caries detecting dye, we stain all the areas that are decayed. We have outer caries and inner caries, but we start with a peripheral seal zone where we begin with a 014 round diamond and clean 1 to 2 millimeters inside the DEJ until no stain after multiple caries detecting dye applications. So that is the peripheral seal zone. After the peripheral seal zone does not stain, then we move to the area inside the peripheral seal zone into the central groove and fossa areas, and we avoid the areas where the pulp horns are. And as we remove the pink and the red, we do that with measurements, and we can go as deep as 5 millimeters from the occlusal surface or 3 millimeters from the interproximal surface towards an axial wall. But we never need to go deeper than 5 millimeters from the occlusal or 3 millimeters interproximally. And this will prevent the exposure of the pulp. Because 6 millimeters will get us close to the pulp horns, we never go deeper than 6 millimeters, measuring axially from the occlusal surface. And interproximally, if we stop at 3 millimeters, we will stop before exposing the pulp. So we measure 3 millimeters toward the axial wall, and then we stop. If there is pink staining affected dentin or red staining infected dentin deeper, we leave that. The first protocol in the paper that Pascal and I wrote talks about cold testing as the first test for every tooth. And if a tooth looks like it's very decayed but still gives a positive response, we always give the pulp the benefit of a doubt, and we allow the pulp to heal. And almost 100% of the time, a vital pulp will seal if the tooth is sealed with stress-reducing protocols that we refer to in lesson 4 of this technique. So our second lesson in the 6 lessons approach is to look at the structure of the tooth. And if we analyze the structure of the tooth, we're able to respect that there is a connection with internally of the tooth that is called the subocclusal transverse ridges. And this paper on the right side is written by Tim Rainey, a partner of ours in teaching minimally invasive biomimetic dentistry over the years. And Tim Rainey, when he wrote this paper, it was based on his anatomical investigations of what the enamel looks like underneath the pits and fissures that you see. And he discovered the subocclusal transverse ridges. We call them Rainey ridges. But if we cut these ridges that connect the tooth side to side and front to back, then the marginal ridge will crack. And the cracked marginal ridge is something that each of us have seen many times. And that cracked marginal ridge is an indication that the tooth is moving in two different directions. And so this area right here, this is called a peripheral rim fracture. And you've seen them hundreds of times, but now you know the name of them. And they were named in the paper that Tim Rainey and Graham Milicic from New Zealand wrote in 2000. And these cracks in the marginal ridges are the origin of horizontal and vertical cracks into dentin. And as we evaluate a tooth, we're able to see that these cracks that extend from the peripheral rim fracture often extend underneath cusps. Now, these cracks under cusps usually do not go into the pulp, and a cusp will be fractured without killing the tooth, the pulp. But if this crack goes vertically, then the pulp is usually killed, and quite often the tooth is lost. And so to understand these cracks and to diagnose them and to remove them is the best way to reestablish a tooth that is connected side to side, front to back, and top to bottom. And so these peripheral rim fractures also induce a condition called occlusal effect caries. So this is caries that is not due to lack of flossing or brushing. It's actually coming from the inside of the tooth, and that biofilm is inside of these cracks, and now that has caused a carious lesion that can be diagnosed through recognizing the peripheral rim fracture. So the occlusal effect caries, they're removed in the preparation. The fracture under the tension cusps on the buccal are removed. And now we have a caries removal endpoint and a crack removal endpoint in a tooth. And this is the final preparation for reconstructing with biomimetic techniques. These Rainey ridges, or subocclusal oblique transverse ridges, when they are removed through traditional GV black preparations, destroy the fracture resistance of the tooth. An intact tooth with the Rainey ridges intact takes about 500 pounds to fracture. If we put an isthmus of 1.5 millimeters with a traditional GV black preparation, the fracture resistance of the tooth is reduced by 40%. If we increase that isthmus width even a half millimeter more to 2 millimeters, then the fracture resistance of the tooth is reduced by 60%. It only takes 200 pounds to fracture a tooth with the missing internal structures, which are very, very common in traditional GV black preparations for amalgam and with composites that aren't bonded. So when we prepare a tooth in the traditional way, we need to realize that we have lost 60% of the fracture resistance of the tooth. And with 60% of the fracture resistant, then that tooth now is bending and flexing and prone to fracture and redecay. This paper by Dr. Monnier and Dr. Ogunasiyan illustrated that a tooth that's not connected side to side now has the ability to create a space for a biofilm. And that space is about 175 microns wide. An average bacteria is 1 to 3 microns. And so we have a biofilm in an unbonded restoration as the tooth, under chewing forces of about 150 newtons, opens and closes that gap and allows bacteria to form. So when under occlusal loading, the cracks propagate, we will have a symptom, and that symptom is cold sensitivity. And this is based on research from Martin Brandstrom. He wrote an important book in 1982 that showed how the hydrodynamic movement, or the pulpal fluid moving in and out of the tubules, causes the pain. There are nociceptors on the odontoplastic processes that pick up the pain of the movement through the fluid that moves in and out of the tubules. And the longer the crack, the more frequent the cycle of sensitivity. And so when we're making a diagnosis of a tooth that has been structurally compromised through a large restoration, we always ask the patient, do you have pain on cold or biting? If you have cold sensitivity, but it goes away, the pulpal side of the crack is remineralizing and the secondary dentin is laying down. And so you can have a recurrence of sensitivity to cold and biting. This tooth on the right, you can see this white crack. This is a fresh crack. And this is a patient who has recently experienced pain on biting and cold. By dissecting the crack, removing the crack without exposing the pulp, then we can reconstruct the tooth now in a way that is connected side to side, front to back, and top to bottom. And we use the same measurements that we use in lesson 1 for establishing the caries removal endpoints to establish the crack removal endpoints. And we don't go deeper than 5 millimeters from the occlusal, but we also go 3 millimeters from the buccal surface. And so this crack-free zone isn't close to exposing the pulp, but now we have the tooth where the reconstruction can be made and there's no crack underneath the restoration, which often happens when a full coverage restoration is placed to try to stop the crack from moving, which it does not do. So if we look at a tooth like this, we use a diagnostic tool that's called the 1, 2, 3, 4 risk assessment. And it's a risk assessment for decay and fracture. And the number 1 stands for, we're looking for 1 crack into dentin. And we look at a peripheral rim fracture, indicating that there may be a crack into dentin, and that's confirmed by asking the patient, do you have pain on biting or cold sensitivity? If the patient says no, there still is a good chance that there is a crack into dentin because of the remineralization phenomena. And so you ask, have you ever had sensitivity to cold or biting? And they may remember that, they may not. But that is one indication that there may be a crack into dentin. Number 2, you ask or measure, what is the isthmus width? If the isthmus width is greater than 2 millimeters, then we know that the tooth is bending and flexing and has fracture resistance reduction by 60%. Not only is it reduced by 60%, but we know that the bending and flexing of the tooth is allowing a biofilm to form underneath, in between the restoration and the tooth, because of the 175 micron micro movements that are present. The third thing we look at is the cusp width. If we have a cusp that's less than 3 millimeters, then that cusp has actually been dehydrated because there's now no connection between the cusp and the pulp. And if a cusp is dehydrated, or it's not hydrated by the pulp, then it's 3 times as brittle and 3 times as prone to fracture. And so we know that that cusp is very prone to fracture. And the fourth thing that we measure is a depth of a box. This box is a buccal box, very easily seen. Most boxes are interproximal, and they would be measured on a bite wing x-ray. And the bite wing x-ray that has 4 millimeters of depth indicates that the restoration is now into the part of the tooth that's referred to as the biorim. The biorim is the 2 to 3 millimeters of the cervical area of the tooth. And that area, if it's not intact, allows the tooth to bend and flex in an unnatural way and is very prone to leakage and decay and fractures at the bottom of those boxes. And so this tooth had all 4 red flags. You don't need to have all 4, but if you have any of these, it indicates that this tooth is not connected side to side, front to back, and top to bottom, and is at risk of decay and fracture. And so the patient did have symptoms, decided to try to reconstruct this tooth. And so as we removed the restoration, we were able to visualize, indeed, the staining shows us areas of occlusal effect caries, and we see a large crack buccolingual and mesial, and there's a crack on the distal also. And the 6 lessons approach says that crack removal is safe 5 millimeters from the occlusal surface and 3 millimeters interproximally. These cusps were onlayed because they were thin, so the depth here is 3 millimeters, and the depth here interproximally towards the axial is 3 millimeters. So by not going more than 3 millimeters axially, 3 millimeters axially, 3 millimeters axially, and then going depth 3 millimeters from the onlaid cusp length. After the cusps were onlaid 2 millimeters, then the depth that was safe to go is 3 millimeters deeper. And so we've completely dissected the cracks, removed all decay, and now the remaining tooth structure is connected side to side, front to back, and top to bottom. There is no decay or any fracture that's disconnecting that tooth. So this is a foundation that now can be reconstructed. And that reconstruction will be called a biobase. And then the final enamel replacement can be placed on the biobase. And that tooth has now been restored for 15 years. So our lesson 3, excuse me. Our third lesson of the 6 lessons is immediate dentin sealing and resin coating. In the hierarchy of bondability, we have the concepts that different parts of the tooth establish the hybrid layer at different strengths and at different times because of the different conditions and locations of the dental hard tissues. So this is a proprietary concept that I came up with 20 years ago. It has helped me understand exactly how to get bonded and stay bonded. And the idea is that if you have your bond strength with immediate dentin sealing at 400% compared to delayed dentin sealing, we had to understand why this happened. And Pascal Magnier published this paper in 2005 that established that if you do immediate dentin sealing and create a biobase and then bond to that, then you will have a 400% increase in bond strength compared to if you take an onlay and try to bond it to the dentin at the same time that you cement the onlay to your tooth. So traditional failures in inlays and onlays, partial coverage, have all been because they were not able to overcome this hierarchy of bondability. And the main concept of the hierarchy is that bonds take time to develop. Immediate dentin sealing allows the dentin bond to develop in a stress-free environment before subsequent polymerization stresses come in contact with that bond. This is a very, very important concept. But dentin is moist. Enamel is dry. If you connect layers of dentin with layers of enamel at the same time, any shrinkage of the composite will move towards the enamel and away from the dentin. Immediate dentin sealing doesn't allow this to happen. This is called decoupling with time and overcoming the hierarchy of bondability. And we do our IDS, we do it with a gold standard adhesive. Gold standard is the designation given by the best team of researchers in the world evaluating adhesive research, and that's with Bart van Meerbeek and his team at Catholic University in Leuven, Belgium. And their meta-analysis of hundreds and hundreds of tests of adhesives show that these three adhesives are the ones that will work the best on your worst day. Are there other adhesives that can come close? Yes, but it takes usually 5 years to establish any type of equivalence. But this science and this research that establishes this is independent of the manufacturers. This is just based on independent research from many universities and many experiments. So using the gold standard that I prefer, SE Protect, you would prime the dentin and the enamel. This is a self-etching primer, and you would do that for 20 seconds with agitation. And after 20 seconds, you air dry to evaporate the solvent. And this priming is bringing hydrophilic monomers into contact with the partially etched dentin. And with the self-etching system, the smear layer in the tubules is in place, and you're able to limit the amount of pulpal fluid that comes into the bonding field. And this is one of the great advantages of using a self-etching priming system. We also use air abrasion to remove the smear layer and compact the smear layer before this step. And then we apply the adhesive, which is the second bottle, and we apply the adhesive in a uniform layer, and we wick away the excess with a clean, dry micro brush. You don't want to air thin this. Air thinning would increase the air inhibited layer, make it a little more difficult to have the perfect bond that you want. But you would wick away the excess. You don't want too much bond, but an ideal uniform layer will be created by just wicking away with a dry brush the excess adhesive, and that will be about 40 microns thick. And then we light cure that for 20 seconds. And so this hierarchy of bondability with gold standard bonding systems approaches the strength of the DEJ. And this paper in 2000 out of the Tokyo Medical and Dental University team, led by Dr. Tagami and Dr. Sano, Dr. Nakajima, Dr. Urevi. This showed that there is a bond at the DEJ area of around 51 megapascals. And because we have the ability to get to 50 megapascals, we can have a reconstruction that is like a natural tooth. So in this hierarchy of bondability, we ask the question, which bonds better, enamel or dentin? Traditionally trained dentists will say enamel. Biomimetically trained dentists will always say dentin, but that's depending on using a stress-reducing technique for the dentin replacement, which is our lesson 4 topic. And so dentin has the potential to bond better than the bond to enamel, but it depends on the time that the polymerization is allowed to develop and strengthen the hybrid layer. It also depends on the substrate, if you're bonding to carious dentin or over cracks or over sound dentin or caries affected dentin or caries infected dentin, and it also depends on the C factor. So all of these considerations affect the bond strength that we're shooting for, which is in the 30 to 50 megapascal range. And this paper by Van Meerbeek shows that if we have overcome the hierarchy of bondability by eliminating C factor, by eliminating decay, by eliminating cracks, then we have the ability to double the bond strength of enamel with our dentin bonding systems that are gold standard. So this is an important paper published in 2003. It's one that all of our mastership students basically memorize, but you will understand that the potential bond to dentin is twice the bond to enamel if you decouple with time and overcome the hierarchy of bondability. So this is a polymerization curve, and this indicates where polymerization stresses are the greatest. And these curves, this is a study out of the University of Colorado, but it confirms hundreds of studies showing the same polymerization curve of, in the first 3 minutes, you have a strong polymerization, but after 3 minutes, then the polymerization tapers off. And after 30 minutes, it's very, 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 very minimal. And so in a polymerization reaction, the shrinkage happens mostly in the first 5 minutes. And that's where most of the stress will come in C-factor configurations. So the polymerization stress is if we can delay them to the 5 to 30 minute time frame, then the hybrid layer is not negatively affected in its developing strength. So if a bonded dentin is connected too soon to the enamel, then 30% of the center of mass will move too fast, maturing to the fast maturing enamel bonds and away from the slower developing dentin bonds. So that light, once it goes on to the composite, it starts moving towards the most bondable surface that all of the mass is connected to at that time, which in a bulk fill situation would always be towards the enamel and away from the dentin, and that would weaken the bond to dentin. And that would create a gap. Sometimes the gap doesn't happen immediately, but the stretching of that hybrid layer weakens the gap, and so you would lose 80% of your bond strength immediately. And then over time, that gap would open and the tooth becomes disconnected top to bottom and allows an area for stress accumulations and bacterial infection. So let's look at this optical coherence tomography from Dr. Ali Sadr, professor at University of Washington, who was at TMDU for 10 years working with Tagami team. If we bulk fill and don't use a gold standard in this 2.5 by 4 millimeter prep, which is a moderate C factor, when we put the light on this preparation and the polymerization starts with all of the composite, as it's polymerizing, there is stress put at the bottom of the preparation. And you will see a gap form real time. That's the gap. Now that gap can be reduced by using a gold standard bonding system and using a composite that shrinks less. But composites that shrink less are usually more flexible, and then under function, they become susceptible to faster fatigue also. So this is the critical area in every restoration, and this is where we need to stay bonded at our highest bond strength. So the way to do that is with a resin coating after the immediate dentin sealing. And so this paper published in 2003 by the team out of TMDU under Pramali Jayasuriya's work under Tagami, Perea, and Nikaido. It showed that if you put a 0.5 millimeter of a microfilled flowable on top of your immediate dentin sealing, then several very important things happen. The bond strength matures, and it allows the tooth to now have what's called a fail-safe mechanism. And it secures the bond so that if the restoration were to fail, the failure would not come at the dentin interface. This is a very important paper. Hopefully everyone here will be committed to the literature. This is really what separates the biomimetic dentist from a normal adhesive dentist. The literature is very solid, and this is important that everyone know that these terms we're using, like immediate detent sealing and resin coating, these are very scientific principles, and we need to understand what's happening. And what happens is when you put this 0.5 millimeter of a microfilled or a nanofilled flowable on top of your immediate detent sealing, it takes a little bit of time, about a minute to a minute and a half. And what's happening during that minute or minute and a half? Well, the immediate detent sealing polymerization reaction is continuing. And we remember that that curve at 3 minutes is really the critical time. You don't want to have any polymerization stress or bulk of composite on top of your immediate detent sealing in the first 3 minutes for sure. But by using this step, not only do we promote this secure bond or fail-safe condition, but we also allow the maturation of the hybrid layer. Very critical in following these protocols is considering the time it takes for the hybrid layer to maximize its bond strength. So we use a 0.5 millimeter of microfilled or a nanohybrid filled flowable over the IDS. It creates a fail-safe or a secure bond, protecting the underlying dentin and the hybrid layer. So for polymerization stress, if you wait, the dentin bond will mature in a low C factor configuration. So here, the C factor is the ratio of bonded to unbonded surfaces. It's the area. You can calculate the area of the bonded. If you have a immediate detent sealing layer of 80 microns, like Optibond FL, then the ratio of the bonded to unbonded area is 1. It's the same. And so all of the polymerization shrinkage will go in one direction. And that's when the clock starts. When you put your adhesive, you've got 5 minutes that you don't want to get thicker than 1.5 millimeters. If you stay less than 2 millimeters in that first 5 minutes, then the polymerization of the IDS and the resin coating is to the 85–90% polymerization, and all of that shrinkage has gone towards the developing hybrid layer. So by waiting 5 to 30 minutes, you decouple or separate the slow developing bonds that are in the dentin with the faster maturing bonds in the enamel. Therefore, the shrinkage of that layer goes towards the hybrid layer. So if you wait, the dentin bonds will mature in that low C factor situation. By waiting 5 to 30 minutes, you decouple with time the slow developing bonds from the fast developing bonds of the enamel and superficial dentin. So this is the rule. Don't get thicker than 1.5 millimeters in the first 5 minutes. Now, you can also put 1 millimeter on top of your 0.5 millimeter resin coating. That resin coating and now that 1 millimeter of dentin replacement here. If you embed fiber into this or put fiber into it like Everex or Everex Flow, and you take that and you put that at that time, you will not exceed that 1.5 millimeter in 5 minutes. So the immediate dentin sealing, the resin coating, and the 1 millimeter of dentin replacement with fiber, those placement steps in that order ensure that you don't violate the Alleman-Della-Peri rule, named after obviously myself and my teaching partner for 10 years, Simone Della Peri from Sardinia, Italy. And so by doing this disciplined and not violating this, this is called a biobase, whether the remaining restoration is done direct or semi-direct or indirect. This is the biobase that is critical to the 6 lessons approach of biomimetic restorative dentistry. So immediate dentin sealing and resin coating is the foundation to increase your dentin bond 400%. And that's the key to staying bonded. Okay, now we come to lesson 4, C-factor and margin elevation. So this lesson solves the 3D problems, the problems of deep boxes, deep cracks, and deep decay. Those 3 D problems are the problems that cause pulp deaths and tooth loss. And traditional techniques involving endodontics and prosthodontics and surgery, crown lengthening, that are quite invasive and expensive, can be prevented by using a C-factor reducing protocols in these deep areas. So the ratio of bonded to unbonded surfaces is the definition of C-factor. It's the configuration. And so the more sides of the preparation, the more competition there is when composites start shrinking. One way to avoid or reduce high C-factor is to onlay structurally compromised cusps, that you would say that are less than 2 millimeters for holding cusps and less than 3 millimeters for buccal cusps. And so we always measure the thickness of our cusp after lesson 1 and lesson 2, caries removal and crack removal. And if we have cusps that are less than 2 millimeters, which are the holding cusps, which would be the buccal cusps with the lower molars or lingual cusps with the upper molars, or if we have tension cusps, which would be the buccal cusps of the upper molars or the lingual cusps of the lower molars, we would reduce those. And that automatically reduces the C-factor and helps you to visualize your caries removal and your crack removal endpoints. So when we look at C-factors, we usually say, does the prep look like a plate? Does it look like a bowl? Or does it look like a cup? And that would indicate a low C-factor, a medium C-factor, or a high C-factor. And when we layer, we use thin layers that are less than 1 millimeters to have a ratio of bonded to unbonded surfaces that are similar to low C-factor preparations. Here's an example of using what we call a delabit, which is a 2 millimeter diameter ball of composite, compressed. And we do that disciplined to make sure that we don't get too thick with our layering, which would increase the C-factor stresses sooner rather than later. So the paper that was published in 2004 by Nikolenko and Frankenberger's team in Germany showed that bulk filling a 4x4x4 preparation will decrease the bond in the pulpal floor to 11 megapascals compared to a layering technique of multiple thin horizontal layers will go to over 30 megapascals. And so 30 megapascals is close. It actually is the average cohesive strength of enamel. So by using 1 millimeter layers in dentin replacements, instead of 2 millimeters, we double the bond strength. And by using 1 millimeter layers instead of bulk filling, we triple the bond strength. And the bond strength now becomes like the cohesive strength of enamel, around 30 megapascals. If we use even more layers and more time, that actually can go to the higher 40s and 50s in bond strength, using the same concepts. And there's another 2 papers that were published in 2014 by Bacalho under the direction of Anthony Verschlush, and they came to the conclusion that the more layers resulted in higher bond strengths, 100 to 300% increase in bond strength, depending on the number of layers. Now, it takes more time to do this, But if your goal is to have a permanent restoration and not to have a restoration that breaks down every 5 to 10 years, then this is the goal of a biomimetic restoration. And we've been using these techniques for 20 years. And so we have thousands, maybe hundreds of thousands of cases that are 20 years old that have no retention form, no resistance form, totally relying on adhesive dentistry. And there is no recurrent decay, there's no fracture. And this is the ideal of a restoration that's like a natural tooth. And when these studies came out in 2014, it confirmed the study that was done in 2004 by Nikolenko, saying that multiple thin horizontal layers are the only way to maximize your bond strength in that critical pulpal area of protecting the pulpal floor area. So when we do layering, a thin layer that's less than 1 millimeters will have a ratio of bonded to unbonded surface similar to a low C-factor preparation. So it's like stacking plates, one on top of another. Thin horizontal layering increases the microtensile bond strength in the dentin. The other technique, and this is every Turkish dentist should be very proud of these slides because they're actually inspired by the science that was published in 2006 by Semabelli, Selkirk University. And when Semabelli published these, I didn't know her personally. I do now, a good friend. She is really one of the main innovators and real heroes of biomimetic restorative dentistry, because her introduction of fiber into the dentin replacement is actually a mimicking of the DEJ in many ways. But the stress reduction of the C-factor stresses that were first shown in 2006 and 2007 by Semabelli and her team are just really monumental innovations. Just so glad that she did what she did in Japan and now continues it in Turkey. She's one of the real heroes of biomimetic restorative dentistry. And so by placing fiber inserts on a pulpal or axial wall, this rib-on fiber deforms under polymerization stresses, and it prevents additional stress on the dentin adhesive interface. This research done at the University of Toronto by El Mwafe and his group showed this very clearly. And this paper in 2007, the same year, by Semabelli, again showed that the stress relief from fiber inserts decreases crack and gap formation and decreases the potential micro leakage. So when we place fiber, we use a thin increment, 2 millimeter diameter ball of composite, compress that into the cavity, and then we take a rib-on square of appropriate size, press that in. You're mimicking the DEJ right now. So the dentin-enamel complex, which is about 200 microns thick, is now mimicked by a fiber composite construction that's about 500 microns thick. So it's about twice as thick as the normal DEJ, but this is the real breakthrough protocol in biomimetic dentistry for the BioBase. So BioBase and raising the box, this breaks the one-piece paradigm, and this is the real area where hundreds of thousands, actually million teeth have been restored without full coverage. When I started teaching this in 2003, I called it raising the box or breaking the one-piece restorative paradigm. And so in a biomimetic restoration, there's always part of the restoration that is done directly. So the difference between direct restoration, indirect restoration isn't part of the categories in biomimetic dentistry now, because every biomimetic restoration will have a direct component. And so when we do what's called deep margin elevation now It's the concept that in these areas that are in the biorim replacement, which would be that area that's deeper than 4 millimeters, where that biorim has been lost, that area needs to be restored separately. It's a separate restoration, and it has the ability to reduce the C factor by doing it separately for a certain amount of time, which means that this most critical and most difficult part of the tooth to bond to will be restored and connected very strongly in that 30 megapascal range. And this is based on a lot of research and a lot of clinical success now over the last 18 years that we've been teaching this to other dentists. And so this concept of a deep margin elevation, you're subgingival, but now you create this elevation and this biobase. This has been tested now in clinical trials in Holland and in France, and we have few or no signs of any clinical inflammation present. We are into the attachment, and so traditional ideas of biologic width infringement have to be totally changed, because a restoration that is not leaking and does not have a biofilm is totally compatible with the connective tissue attachment and will not have signs of inflammation and bleeding. This is another big shift in the paradigm of restorative dentistry. So the idea of biologic width violation needs to be understood as an infection underneath restorations, crowns mostly, and subgingival fillings that are leaking and allowing these micro movements to allow biofilms to develop, and that is a constant irritation to the connective tissue. In contrast, the biomimetic restoration that is sealed and stays sealed, is bonded and stays bonded, does not allow a biofilm to inhabit between the tooth and the restoration, and the attachment is very sympathetic, it's very happy, it becomes a connective tissue attachment and a epithelial attachment, has normal sulcus, but these published findings on this deep margin elevation, once these have been published and repeated, every university in the world should have been teaching this, but it takes time and people don't read the literature. But the survival rates in this study that was published 2019 shows that the cumulative survival rate of these deep marginal elevations over 12 years is over 90%, not 95%, 96%. Some of the doctors that I've trained 12, 13, 15, 18 years ago report no failures with over 10,000 restorations. So these concepts are not new. They're scientifically and theoretically established. There's every dental school in the world should do these, know these, teach these. The science is available to everyone. We just need to read it and implement it and be guided by mentors who have been doing it. Here's a case that I did 20 years ago using these low C factor preparation and incremental filling techniques. And as these boxes have been restored, we have now, 20 years of success with these techniques. So we do our immediate dent sealing, our resin coating, and then we do a thin shell. And that thin shell would be 1 to 2 millimeters. And that would be on the peripheral seal zone, which is the caries-free and crack removal endpoint-free area. And that layer of composite has a ratio of bonded to unbonded surfaces that is a very high C factor, low C factor, less than 1. And so if you can look at this illustration and see that that increment or that shell has a low C factor configuration, and you understand what that means, and you will be able to do that successfully. And it takes amount of time to do that. And that, again, is part of the decoupling with time, which is allowing all of this immediate detonant sealing and resin coating to mature. And this will protect this pulp for its lifetime. So again, the 3D problems of cracks that this tooth has and decay that this tooth has and a deep subgingival box that can all be overcome by using horizontal thin increments to create the biobase. And that is the answer to deep boxes, deep C factors, and deep cracks. Now we get to lesson 5. We're adhesively bonding to enamel on top of our biobase. The tensile strength of enamel is around 30 megapascals. We have very easy to match that. By beveling the enamel, we increase that ability to bond that high strength. So we recommend that bevels are placed. A saucerization shape of a preparation reduces the C factor. This instrument called Sonixis by Cavo is a very easy way to create an ideal bevel. In the deep boxes, we bevel the enamel if it's thicker than 1.5 in the bottom of the box. But if it's deeper than 4 millimeters, the box, then we do a butt joint. We do not try to bevel enamel in that critical the 4 millimeters deep into a preparation. And now as we prepare the enamel, or the enamel replacement, our onlay preparation, we would again measure the thickness at the base of the cusp after caries removal and crack removal. And then we onlay the cusp at a uniform thickness of 2 millimeters by measuring the head of a 330 burr and make depth grooves with that. And then we would turn our handpiece sideways with a flat diamond, and we connect the grooves with a straight diamond. This gives us a uniform 2 millimeter reduction and gives us room for our onlay that's made semi-directly or indirectly. So here's a case that we did. After we reduce that 2 millimeters, we can create a modified bevel with a large round diamond in aesthetic areas, do a hollow chamfer, but nothing for resistance form or retention form. So we onlay the cusp when we have that tension cusp that's less than 3 millimeters or a holding cusp that's less than 2 millimeters. But basically the preps look relatively flat, and preserving thick cusps contribute to the fracture resistance of the tooth. By onlaying cusps that are greater than 3.5 millimeters, that can increase the likelihood of a catastrophic failure. So it's better to preserve cusps that are greater than 3 millimeters. That's based on a paper by Fennis. He's also the one who investigated fiber underneath an onlay to make that a fail-safe situation. So the measurement of the tension cusps and the holding cusps allows us to make decisions on which cusp to onlay. And if a crack is under a tension cusp, it's easy to see that by onlaying it. And so the occlusal effect caries that can happen associated with the crack is easier to visualize in these cusps that are onlayed. So the advantage of onlaying a cusp, it's more of a visualization to ensure lesson 1 and lesson 2 accomplishment of those protocols rather than a mechanical strengthening. So we're not onlaying cusps for the same reasons as we used to onlay cusps for a gold restoration, for example, an onlay restoration. This is actually for visualization and to decrease C-factor stresses in the reconstruction of the dentin base. Visualizing the cracks, we see the occlusal effect carries associated with the cracks, and then we can appropriately treat that without exposing the pulp by using our measurements. So the preps should be relatively flat with rounded internal line angles. When we bond to our biobase, we aerobrade that. That will increase the bond to around 40 megapascals. And then when we cement to our biobase, we do that with cleaning the aerobrated surface with 37% phosphoric acid for 30 seconds. We rinse and dry. Then we aerobrade the intaglio surface of a composite onlay, or treat the intaglio surface, if it's a ceramic onlay, with hydrofluoric acid and silane. Clean that with 37% phosphoric acid, rinse and dry. Place uncured adhesive on the biobase and on the intaglio surface of the onlay. And then we seat that with heated composite, heating the composite to about 100 degrees Fahrenheit. And that makes it very easy to clean up using the heated composite cementation. Very easy cleanup. Here's a final case through the steps. Biobase restoration. And our last lesson is occlusal adjustment. This is the easiest of the lessons for a single tooth, and that is to just remove all the interferences of the working and the non-working. And this is similar to the interferences that you would learn in your dental school training. But in occlusion, we do have stresses, and those stresses can crack a tooth and crack a restoration. But if we put fiber, then those cracks can be prevented. And that is the breakthrough of the biomimetic restoration, with the fiber mimicking that William Fennis and Semabelli, and now Pascal Magne with Everex, has shown to be a fail-safe condition. By putting fiber underneath the onlay preparation, it prevents fractures going into the tooth, and it prevents catastrophic failures. When we adjust our occlusion, the last technique we'll show you is called the 3-paper technique, where you use single paper to find a working interference on the restoration, and then you would deepen the fossa or lower the cusp just like you would normally do. But then when you're working for your balancing interference, then you would take your, sorry, didn't get our last slide. I had to leave a couple of slides out. Oh, this is the last slide. So the 3-paper technique is that you adjust the occlusion on your working side, and then you take the single piece of paper and go to the non-restored side and have the patient chew on that. And while they're chewing on the non-restored side, you slip in 2 pieces of paper on the restored side, and that will pick up a balancing interference, a non-working interference, and then you remove that. And then that's Gary Enterbring's 3-paper technique to remove working and non-working interferences. That's the end of the lecture for today, and we sure appreciate the opportunity to share this with you. And like I say, we'll be online for review, and so you'll be able to look at biomimetic dentistry and go to the next level of your ability to restore a tooth. And hopefully we can have some more interaction on Instagram, or if you want to participate in our mastership training next year, we still have a few slots left open for our January start date. So hope to see you. And until next time, we'll always say, get bonded and stay bonded. Thanks so much.
So as we already exceeded the session duration, I have a short question to you. It is regarding the biobase. During creating the biobase, you recommend us that we shouldn't exceed 1.5 millimeter thickness, even though we use the low shrinkage material like Everix posterior or Everix flow. Is that correct?
Well, it's a biobase can be anywhere from 80 microns in thickness to 500 microns in thickness to 5,000 or 7,000 microns in thickness. The biobase is the dentin replacement. So it just depends on how much dentin is missing after caries removal and crack removal. And those areas that are missing should all be restored before the 2 to 3 millimeters of enamel replacement are fabricated. And so if you have a large area of dentin missing, then you would make a thicker biobase and the Everex would be thicker. But the first layers of immediate dentin sealing and resin coating, that's in place in every biobase, no matter what the thickness is. So think of the biobase as the dentin replacement, and think of the immediate dentin sealing and the resin coating as the DEJ replacement. And so every biobase has the foundation of a DEJ replacement, and then the thickness of the dentin replacement will just depend on how thick the how much dentin is missing.
Okay, thank you very much for your response. So what do you think completing the restoration in 2 sessions? In the first session, just replace the dentin, the missed dentin structure, and then create preparation in the second session for an onlay restoration, for example. Do we need to complete the whole restoration in 1 session?
Yeah, so the technique to restore the whole teeth in one session can either be done with biobase creation and take an impression and make a chair side onlay. That can be done, many ways. Didier Dici wrote a book in 1998 that showed a semi-direct technique can be made chair side. We teach that in our course. But you can also use a CEREC machine if you have that available to make that. But you can also recreate the whole tooth using the technique that Simone Della Peri pioneered and published in 2002 called the stress-reduced direct technique. And so all of these techniques, you need to be trained, you need to have mentors. We need to have some fully trained mentors in Turkey. Hopefully we are able to do that in the near future. But the concepts that you're using, are all being taught by somebody somewhere. You're learning them somewhere. You can get a lot off Instagram. We wouldn't recommend that you get them all from just Instagram. You need to have some mentors, and I've listed 50 mentors that I've trained, in the last 18 years. But we don't have anybody in Turkey right now that's fully trained. So hopefully we can make that happen sometime in the near future.
Okay, thank you. So thank you very much with these last words. It was a great pleasure for us to listen to your lecture. And on behalf of the organization committee, I would like to express my best regards to you and hope to see you in a face-to-face congress in a very near future.
That would be great. That would be great. Okay, so thank you very much for this opportunity.
Please stay safe and see you soon. Bye.
Bye-bye.